Okay, well, and my slides are up, so that's good. And I want to say hello again to all this community here in Chattanooga, and appreciate very much the invitation again. So I'm going to start off talking about aneurysmal disease, but it will be more case-based than just, a discussion of aneurysms, which Dr. Cuso will go over treatments and other things with us. So let's get started. And as everything starts with these talks, we have to really think about the normal layers of the arterial wall and its anatomy. This is something that's very important, and wall disorders, endothelial dysfunction, those are things that were discussed a little bit at our CME meeting last night. But as most of you know, we have an endothelium, we have a media, and we have an adventitia, all three layers constructed a little differently with some elastic membranes in between. But this is where we really look to for everything that we do in the arterial world, whether it's atherosclerosis, whether it's other kinds of arteritis, or any other thing that we look at. So when we do look at this, the layers, one of the things that has become more evident since I was first in this is that very important role of the intima in terms of the management. It's not just a cellophane wrapper layer that we were talking, it's just the inner lining. It's a very large organ. And stretched out, it's very large. But it has many, many different functions and helps to control the functions also of the other layers, which sometimes I think, at least I know myself, I just sort of overlook that. But it's a very important layer. The media is the muscular tone, and the adventitia holds it all together with a nice structure. So with that very brief introduction of the arterial wall, let's talk about aneurysmal disease. And we know that the sequelae of aneurysms, and when we talk about aneurysmal disease, it's usually what? We're asked to look for aorta, popliteal, pseudoaneurysms. Those are very much the bread and butter of what we do in the vascular lab. But we want to think about also those other symptoms and signs of that, and importance of knowing when we need to say, whoa, this is big enough that we're worrying about rupture. Distal emboli is always there in the background as a potential for our patients. And sometimes it's the first sign that you need to go and look for an aneurysm. They do compress other structures. Arteries can, in general, in terms of compression syndromes, but for aneurysms, they will create stress on the other structures. And then fistulae can form if the arterial and venous walls are in close proximity and basically bugging each other to the point that they connect. So signs and symptoms for aortic aneurysm, and I'm not going to read these out. You can take a look at this, but we want to be aware of those signs and symptoms for an aortic aneurysm, and this is really a top focus. That's the most of what we do, right, is look for an aortic aneurysm. So some pictures, just some images of a normal aorta, and the golden rule with this is always that the abdominal aorta should taper as you go distally, or at least not enlarge. That 2 centimeters is considered the upper limit of normal. I have seen some larger aortas in some larger patients in terms of even height or other kinds of conditions where a patient may have a larger aorta, but it's consistent all the way down. There's no outpouching, there's no enlargement. As you see in the picture on your left up here, or I guess on your right, that this is an ectatic aorta. It is something that is widening out. Nothing really to speak of here, no alarms being set off, but you notice that there's atherosclerotic disease in this area. Atherosclerosis can weaken the wall, dissections can weaken the wall, all in just in terms of age and stage, and hypertension, those things can weaken the wall. So between 2 and 3, we say that's an ectatic aorta. This image, for some of you, would go back way before you ever started scanning. It still has ATL at the top, which some of us know that abbreviation. But this was one of the first aneurysms I found, because first, in doing work Back when I started, it was carotids and arterials, not venous yet, and certainly the abdomen was the domain of radiology ultrasound. So here we see what is really a fusiform aneurysm, even though it looks like it may be a little saccular, but you can see the calcification shadowing out some of the wall, and that this has some mixed plaque. So let's take just a quick look at that. The two types of aneurysms we really discuss in terms of their structure and their shape are going to be fusiform or saccular. So when we talk about an aneurysm as well, and this is important for you to help to differentiate for the people that are your patients and for the providers, that a true aneurysm is going to be the stretching of all walls. Okay? Sometimes we can see areas that, and I've seen it in the abdomen, where is it saccular, is it fusiform, is it even a true aneurysm, or has there been an injury where this is somewhat of a false aneurysm? I've had some of those things to have to debate with myself and others and other imaging. But a true aneurysm is going to be a stretching of all three of those layers. A false aneurysm or a pseudo-aneurysm is going to be an injury with a contained hematoma, a bleed out into something that may actually thrombose or not, and we have to be careful when we look for these things. So that's just the brief overview of those types that we might see. And here we see a lovely image, well done, well gained. I really like it when images are not so fuzzy that you are kind of guessing where the wall is. Take a moment, and this has always been one of my soapbox issues, take a moment to change the gains to make it so that it's really an image that can stand up and say, yes, I did a good job getting this. You can see the spine caudal to this or deeper to this, and nice measurement. If you say it's fusiform, it should be fairly even in the anterior to posterior and the lateral measurements. If it's not, then it's not truly just this round circular fusiform. This is again a very early image I got, but it's one that has stayed in my files because it's a beautiful saccular aneurysm. We don't see this nearly as often as we will see a fusiform aneurysm, but you also see in the color image, and color was newer, not new, but newer at that time, what we call the Pepsi-Cola sign or the yin-yang of blue and red circling in and out of this sac. So that's also something that can give us a nice highlight of the shape of this. All right, with those brief introductions, I'm going to give you a few cases, and these are cases, I know that we do aorta, endografts certainly, for those of us who do look at the abdomen and look at the aorta. Endografts are a big part of most lectures that I've ever done about aneurysmal disease, but I'm going to do a couple of zebras in this, a couple of different things, and hopefully, and I'd like you to, in this a little bit cool room and us having had all morning sitting, participate a little bit. I love to hear from you as well. So 36-year-old male presents to the ER with abdominal pain. He had kind of an acute abdominal pain, denied any injury, which is important in this, or chronic illness. So he was sent after some other testing. He ended up in the vascular lab, and these images were collected by a colleague of mine at that time at University of Cincinnati. So I want you to, for the sonographers, the interpreters, anyone who looks at this, this is his proximal aorta. You can see the celiac coming off in red there. So we know they're above the celiac. What do you think about this waveform? Does this look normal? How many yeses? Speak up. Normal? Abnormal. Who says normal? Okay, and abnormal? And I will tell you, this is really a pretty normal signal in this aorta. So sometimes we have to, and again, one waveform in one place doesn't say that is all normal. At this point, it's in a normal velocity. It has a pretty good rise time. It does have some end diastolic runoff above the baseline, but you're above the renal arteries. I expect that if the renals are normal. So that does tell me as well, even if I couldn't see the celiac, I'm pretty high up. So here's the celiac, and here's the SMA. Now, our aorta is in that normal 60-ish range of velocity, centimeters per second. The celiac artery is at 101. The SMA is at 123. And what do you notice first about this is that they both look very similar. The celiac looks like the SMA and vice versa, right? Now, the first question you would ask, because you would expect the SMA, if this patient were fasted, again, he presented to the ER. He probably wasn't fasted. He probably, had had something to eat. So this first signal to my colleague when we talked about this case later wasn't alarming. It said, have you had something to eat? Yeah, okay. Well, his celiac, and it looks very normal there. We don't see a lot of atherosclerotic plaque in the aorta in this one, as we saw in some of the previous images I showed you. She gets to the midsection of the SMA, because again, follow it down. The fact that the origin of the SMA is normal is wonderful, and most of the time, in a 36-year-old patient without atherosclerotic disease or anything else, he's got acute abdominal pain. She gets to the midsection of the SMA, and we're seeing 377. And not a lot of rise in the end diastolic here. But there is a big area of stenosis with, and this is always the important thing for all of, especially our newer sonographers, post-stenotic turbulence. Don't just show a high velocity, show the post-stenotic changes to really confirm everything in the diagnosis. So, what do we think about this? How unusual is it to have a mid-SMA stenosis? Anybody ever see one? Not at the origin? Don't see any takers? Okay. So my colleague, who is a wonderful sonographer, she went to, again, bring everything up. Take a moment to whether it's changing transducers, changing frequency, zeroing in on it. She notices that this is a rather large section, bigger than the origin, which is not usual in the SMA. And she shows a thinner color band than you would expect. And these are the images she got, which are just beautiful. Now, still, why is there a stenosis in the midsection of the SMA? Okay, this is the typical range. This is measuring at its largest in a long axis view, which you do want to get a transverse. She found it hard to get transverse on this. So at least over a centimeter, and the upper limit of normal is about 3/4 of a centimeter. It looks dilated. It doesn't look strikingly huge, but it's dilated. All right, so the residual lumen, the measurements over here were of what is that? Is that plaque? What is that sitting on the wall there in someone who didn't have any previous disease? 0.35 cm residual lumen. So now I'm going to engage you a little bit on this, and don't shy away, please. So here are the options. What do you think? This is an SMA stenosis with atherosclerotic plaque. This is a 36-year-old African-American gentleman who had no real history of atherosclerosis, but African-American males, he smoked. What's going on? So it could be that. No stenosis. These velocity increases are just because he's postprandial. Does that make sense to anyone? Yeah. Because he would be elevated throughout, not just in the middle of the SMA, and then those wonderful, and again, take the color off, look at it in 2D. She got very definitive images. Could this be a dissection that is creating a stenosis? Okay, that's one option. Who thinks that might be possible? Come on, help me with your hands. Yay, no, okay, all right. Or is this median arcuate ligament compression of the SMA? Who votes for that? Okay, all right. Here's, again, choices. Who thinks A? Come on, I want you to, because we're going to be heading to lunch soon. Wake up a little bit. Who thinks A? B? C? Good group. D? Now, D can't be it because does the median arcuate ligament, and it possibly, and Dr. Cuso could tell us, but it's the celiac you're worried about. It's not the SMA you're worried about. I don't know if there'd ever be an anomaly where you would have that. I don't know that I've ever seen anything or read anything about that. But the answer is that this is a dissection. What nailed the diagnosis is location, good imaging, really looking for some evidence, and that is a laminar thrombus in the false lumen. And I'll tell you, my colleague, this patient came back about, I guess it was 3 months, maybe 6 months later, and I was the one up to bat for imaging. I found nothing. He comes in with an SMA stenosis in the midsection, and I'm going through it and go back and I look at her images again. Did he need surgery? Dr. Cuso, would he need surgery with this for a dissection? I thought maybe, but our physician there put him on an aspirin therapy, and he cleared it up. Now, if he hadn't, then there would have been another course. But here I am like, where the heck did she find that? And it was gone. Okay, so that's case one. Here's another one. This is a 68-year-old male referred with a history of smoking. He'd quit 5 years ago, and he comes in for his Medicare screening. No symptoms, nothing, just age and time to do this. So the image, the B-mode image that you see there, on your left, I always get that mixed up, I have to actually turn. So on your left, and then the color image on the right, there's a video of the B mode. Here's a video of the color. And we see a nice kind of straight laminar flow in the color image. So does he have an aneurysm? On first glance, would anyone here say, that looks pretty normal? And yeah. But, again, careful imaging, there is a break in the arterial wall here. There isn't the same brightness all the way across, and you see the wall, kind of the brightness of it, and the pointer doesn't work very well here, but where it's being measured with the calipers, that again, that's a saccular aneurysm with laminar thrombus in it. And if you just went quickly through or used color and then kind of, went, and this is right at the level of the celiac and the SMA. So again, I encourage you to take those moments, and I encourage anyone who schedules to give people extra moments to change the settings, to take a look, because when we looked at the video, you could see that bottom part pulsing out, and it just didn't look right. So this was a saccular aneurysm of some decent size here. Okay, so an interesting aortic aneurysm case that could have been missed, especially if you didn't have really clear imaging. I'm not saying that every time you miss something, it's your fault. Sometimes we don't get a clear view, and that's definitely true. All right, here's a patient who comes in, and as part of their first pre-op dialysis workup and mapping, of course, we look at the brachial artery. We all do. Does this look like a normal brachial artery waveform? And brachial artery. Does that look pretty good? Good. I'm getting some, yeah. Say it out. Good. All right, here's the brachial artery, and these are all at the antecubital space, but one is more cranial, one is more caudal, proximal or distal is the other term for this, but cranial or caudal. And in the vein world, just so you know, they're now saying more central or peripheral. So we have all these words for going up and down and closer to the heart and away from the heart. But this is another one. This looks like a good signal as well, right? Looks very normal. But in between these, there's this. Completely unexpected, right? Now, in the brachial artery, this close up, and as you're going down the arm, it's deep enough that he didn't feel anything. I truly didn't palpate it. I was like, I should have maybe, and then I did afterwards. Oh, it feels lumpy right there. But this is a saccular aneurysm. Again, was there any injury? Did anything happen? I've seen these in the subclavian arteries. I've seen them in other places. And again, this is really important. This patient is going for dialysis access. So an unexpected brachial, whoopsie, why is it not moving? Oops, because I'm not hitting the right button. There you go. This is the brachial artery. And the brachial artery, again, we have so much ability to Google. I used to have to find some chart somewhere, and yes, I go back that far. So all you young people, it was much harder. Now you just pick up your phone and you say, what's the normal size? Well, it's not that, right? So it's good. Love it. All right. So again, careful looking, and if you're asked to look at the brachial artery, I at least scoot up and scoot down to make sure. They say, all I need is just this. I still am going to thank you. I'll still scoot up and scoot down, make sure I don't see anything, especially for these cases that you're going to be a lifeline creator. All right, this was a really fun case for me. This is a 28-year-old male who came in, and the referral said he had a 3.2 centimeter AAA identified on a CT scan, and I got no other history. Again, earlier days, we didn't have the whole epic chart of everything that ever happened to anybody. And of course, if a patient walks in and you've never seen him before, he was actually from New England, comes in, I get nothing but look for this aneurysm. I'm looking at his proximal aorta, and it's 1.68, and then I go to mid, and it's tapering. Okay, not a big deal. But then I couldn't see because there was some abdominal gas, so I go down low toward the umbilicus and come back up. And we have, if you look at look at the right side, the distal, 1.36. Well, that's not huge, and it's certainly not as big as what they saw, but it's not tapering. And there's some kind of plaque or something in it. It looks a little junky along the walls at the midsection. So I was like, okay, what's this? And then as I go back up a little bit, I see two aortas. This was not another like enlarged artery. And I thought, this is great. I'm going to call the chief and say, there's two aortas. Is that possible? And he would laugh at me like he did sometimes. All right, but I didn't. I turned on color, and these were two. I could follow the smaller one up. I could follow the bigger one up. And at that point, I looked at him and I said, tell me something about your history. Oh, I have a bypass in there. Oh, okay. Well, why would he have a bypass that I couldn't see coming off mid-aorta? Because, and here it is, his aorta and his bypass close together. The aorta kind of fizzled out, and the bypass actually where they saw the largest diameter was where this was splitting into iliacs. This gentleman had mid-aortic syndrome. Anybody here know mid-aortic syndrome? It doesn't happen often. I looked it up again last night so I could get the numbers in my head, like 1 in a million, and it's mostly in juvenile stages. When he was a child, and he could not describe it very well to me, he had a huge bypass put in. He had, and the next one tells you, he had a mid-aortic syndrome. Again, coarctation is higher up on the aortic arch. Mid-aortic syndrome it's descending, but you're not in the abdomen yet. And some people are born with this, some children. Rarely seen in adults, but more often in children or adolescents. And the graft was placed in childhood, the left renal artery and the SMA connected to the graft. So now I'm on an adventure, right? Now I'm on a whole adventure. And the right renal artery and the celiac axis arose from the native aorta. Didn't volunteer anything, but then again, I looked in EMR, which we did have. And I'm like, oh my gosh, well, that would have been nice to know at the beginning. So I confirmed that was a large thing distally, but it was a graft meant to be that large. So again, history. We have to have time to look at the history as well. All right, so here's one, too. We've got a few more minutes left. A 62-year-old female, hypertension, smoker, abdominal bruit. Here's a proximal aorta. Is this normal? Anyone think it's normal? No. It has a visible bruit in the spectral Doppler spectrum. You have a very high velocity of 193. which as we looked at some folks yesterday, if somebody's younger, they may have a velocity of 140, 50, 60, I've even seen 180 in a young person. But this is with a Bruey, and it doesn't look like a normal waveform. The waveform tells us abnormal. So now, this is not a measurement of the aorta, this is a measurement of the celiac artery coming off. So the celiac artery is quite dilated. A celiac should typically be 6 to 8 millimeters, and this is 1.4 centimeters. So as we see this, and the aorta had atherosclerotic disease and a stenosis. So that atherosclerotic disease has migrated into the origin of the celiac axis. There's a very tight stenosis and post-stenotic dilatation, which happens after a tight stenosis many times, and something we should look for. So going into that celiac, it has a very high, 375-ish, and then going out beyond into that aneurysmal dilatation, you see the post-stenotic turbulence. And again, if you're not sure about something being stenotic or not, if the waveform doesn't degrade into post-stenotic turbulence, you're probably not in a hemodynamically effect kind of area. So here's the celiac, or the splenic artery now coming off of that. The hepatic artery below that going, running off to the side, it looks dilated too, but the focus was on the splenic at this point. The velocities are high, but they're also, you see the post-stenotic turbulence there. And the splenic artery, again, look it up. If you see something and think, is that too big? Yeah. Now, where do we usually see splenic artery aneurysms? We talked about this yesterday in the hands-on too. Are they usually at the takeoff? They're usually where? Anybody? Hilum. They're usually, thank you, Tina, distal. They're usually at the hilum. So again, but this one is dilated because there's the high jet and everything's stretching out, and the splenic gets involved as well. Here's the hepatic artery, which again shows the post-stenotic turbulence. So proximal aortic stenosis at the celiac trunk, and post-stenotic aneurysmal dilatation of the celiac and splenic arteries. Okay? So not your typical aneurysms, but again, we have to look. Now I'll go back to something a little more everyday that we see. Here is an EVAR. So we see the endovascular repair of the aorta. And one of the things, besides just the change in size of the sac, is the sac asymmetrical? Is it round, or do we have a bulging? This one's more egg-shaped, and we see this. So should the graft material in any residual aortic aneurysmal sac, and you have a graft in there, should it ever be moving like that? I don't know. Can you play that one again? I don't know if I can go back and do that. Can I? Let's see. Yeah. There we go. Okay? So this is movement of the graft itself. This is going to be before you do anything else. This is an endo leak. Okay? That is definitely abnormal. Now we see one which is one of my favorite cases as well to go over with people when they're looking at endografts. This one was fairly recently placed. I can't remember if it was maybe 6 months, and we saw the patient. So it looks like a very symmetrical round measurement. The residual sac had gotten a bit smaller. Take the Doppler, look with color as well, but take the Doppler and move through the sac, right? We've all done that. Did we hear anything? Does anything make a noise? So here, in this area, which also is hypoechoic, that's a big sign to sample that area, that we don't see a signal. But at some point, there is a signal, and I don't know if you can see this on the left image here, very what I call ghosty. It's just kind of there, but very, very hazy, right below the limb. So is this an endo leak? What I would ask you to do is either change the patient's position and get that area out from under the very bright limb, because when we're between two bright areas, the limb and the aortic wall, what can we get? just like in the subclavian, you can get a mirror image because it's bouncing back and forth. So if I see this and it didn't really look like, okay, that is an endoleak image, then I went right up into the limb, same image, same waveform, only stronger. So this is not an endoleak proof here. This is a reflected signal from the mirroring between the bright wall of the endograft and the bright wall of the aorta. So I finished, oh my God, I never finished just on time. I'm so proud of me right now. So, okay, so this is, I want to thank you again. I want to thank VIC and Tina and the Lasars for inviting me in. And now I'm going to give you a little bit of a shocker image and what Josh said earlier, something about the carotid criteria being created in the 80s. And even though I can usually stand up pretty straight, I started in the 80s. This is me with my first machine. It was the first ultrasound machine. I went to different places asking for help, and I will say, honestly, time flies. It's been 40 plus years for me now since that. And all the buttons and knobs, I was learning carotids and cardiac at the same time. You can see there's a monitor on the top and on the bottom. I had to go like this to get around the machine. There were foot pedals. Press the foot pedal, the paper starts coming out, you press it harder, it cuts it. You press the foot pedal over here, you turn to Doppler. It was no color, grainy image, and figure it out. I went to 5 days of training, and I came home scared to death, always nervous. He'd come in with the angiogram, and I'd be like, oh, no, please don't even tell me. I've been doing this all day, and I don't know. But this is where it all started, and as Josh said, you know, there were people who created things back then. I was the recipient of being able to use this machine when people at bigger institutions were going, how'd you get a duplex machine? Wet behind the ears, you know? And anyway, enjoy your journey with this. It is a journey. I know you're tired every day, but it is a very valuable profession, and I'm glad that we have so many people still dedicated to it. Thank you.
Aortic aneurysms sometimes present in the worst of tragedies, and they present sometimes initially as just a rupture. And that's what we're all trying to prevent here. A rupture is a highly mortality event, and not a whole lot of people make it past. Aneurysms are present in about 8% of males older than 65. It's the 14th leading cause of death in the United States. Ruptured AAAs are 5% of sudden deaths in the United States. 5-year cumulative rupture rate of incidentally diagnosed aneurysms is around 25 to 40%. And only about 25 to 50% of patients with ruptured aneurysms survive long enough to come to medical attention. And the case fatality rate is also very high. Here's normal aortic diameters. You can see progressively as we go from the ascending aorta down into the infrarenal aorta, the aorta gets naturally a little bit smaller. What causes aneurysms? There are several things. We know that it's a degenerative process. It includes atherosclerosis, some inflammatory changes. It can be infectious, genetic, or some traumatic conditions. In the vessel layers of the aorta, it's usually the medial layer that we see degeneration. They include an inflammatory component, just like atherosclerosis. The risk factors we see the same for atherosclerosis as well. And we know that inflammation does occur in the media and adventitia layer, which causes severe weakening of the aortic wall. Genetics can also play a large role, up to about 20%. We see it in families. And then there also can be a infectious risk, and those are very, very difficult cases. Again, Tish talked about the morphology. Just a brief bit about morphology. When we see the saccular aneurysms, the issue is wall tension. So in a fusiform aneurysm, the wall tension is distributed throughout. In saccular, it's very focused and increases rupture risk. So we have to pay close attention to those. Finding aneurysms is usually having a high index of suspicion. We need to do a routine physical exam. A lot of times if you palpate the abdomen correctly, you can feel them. And again, they can be a lot of times an incidental finding. If we look at the risks of aneurysm formation, there's a lot of positive risks that we see in all of our patients, but the negative risks are as equally as important. If we look at race, diabetes, if you quit smoking, you can actually reduce your risk. Exercise at least once a week and eat your fruits and vegetables. Smoking, again, like I said, in this area, just a high degree of very young people starting to smoke. It's associated with a 3 to 5-fold increase in the prevalence of aneurysms. Screening is incredibly important. The SVS guidelines for screening basically say men and women from 65 to 75 should get screened if they have a history of tobacco use. Or men and women older than 75 with a history of tobacco use who are in otherwise good health and have not previously been screened with ultrasound need a one-time ultrasound screening. If you have a first-degree relative, then you should also get screening as well. Clinical presentation of aneurysms, if a patient comes in with significant flank pain or abdominal pain, that is an indication for more urgent repair. It means that the aneurysm is likely rapidly expanding, causing pain and getting ready to rupture. Multiple types of imaging can be used to evaluate aneurysms, including x-rays, ultrasound, and CT scan mostly. We use CT scan primarily for the repair planning. Ultrasound, though, is a very cost-effective and safe way with high sensitivity and specificity. And in a pooled analysis of 4 randomized trials, including more than 125,000 folks, a one-time ultrasound screening in men greater than 65 significantly reduced their aneurysm-related mortality out to 15 years. So ultrasound saves lives. This aneurysm probably should have felt on physical exam, but a lot of them are found on incidental findings. So who gets fixed? If you're a woman and your aorta is around 5 centimeter or greater, men 5.5 or greater. Below 5, not really, risk-benefit ratio doesn't really work out for you in terms of fixing it. We fix saccular aneurysms and symptomatic and ones that are rapidly expanding. Guidelines that the SVS recommends prior to fixing an aneurysm include managing comorbidities and medication. Recommend to quit smoking for at least 2 weeks before, and also a statin medication. So if you look at statins, this is a study again on the VQI database that looked at a large population of patients undergoing aneurysmal repair, and they saw a significant improved 1 in 5 year mortalities if you started the statin prior to the surgery. And even if you started afterwards, you also got the same benefit. So the birth of vascular surgery actually began with the treatment of aortic aneurysms. The first modern repair was performed in 1952 by DeBost. It didn't have a great results. It was actually when the organ was rejected, and then in 1954 we had our first successful synthetic cloth that was placed in a dog aorta that actually worked. And then most of the advances were made down at Houston at Baylor. Dr. DeBakey had a huge impact on this. He collaborated with another professor, Thomas Edman, and a Philadelphia textile engineer, and they built a new knitting machine to make seamless Dacron grafts of all sizes, shapes, and configurations, and they put them in people. Even the Duke of Windsor came to Houston and had his aorta repaired with a really good outcome. Dr. Silagy played an important role in the development of vascular grafts, and he introduced a Dacron graft that bears his name. He was one of the founding fathers of SVS and the Journal of Vascular Surgery. He did a televised open repair of a AAA, and what helped really the repair of aneurysms was effective anticoagulation and safe anticoagulation, antimicrobials, and good angiography. This is down in Texas at Baylor, where this is how they learned. It was just piled into a room. They watched Dr. DeBakey operate. So the principles of open aortic surgical repair, fairly simple. You open the abdomen all the way. It's maximum invasive. You move the abdominal contents aside and expose the retroperitoneal aorta from top to bottom. It involves a clamping of the aorta and a clamping of the iliac arteries, and essentially opening the aneurysm sac, over sewing the lumbars that are there from the inside, and then sewing in your graft. The biggest thing about this surgery is clamping the aorta. There are some patients who do not tolerate a clamp very well. I had a patient like that about 10 years ago in Virginia. She was about 90 pounds and around 75 years old, and as soon as we clamped her aorta, she coded. And her heart couldn't take it, and we couldn't get her back. So clamping the aorta is a serious thing. Here's a position of a endograft here within the retroperitoneum. This is Dacron graft legs kind of going down to the iliacs. So there's a downside for operative repair. It's maximally invasive. You can have major morbidity, moderate rates of death, or you can have medically or anatomically inoperative patients. So there was a desperate search for new management of abdominal aortic aneurysms, and it came basically in 1990. The first case was performed by Dr. Juan Perotti in Buenos Aires, and it was on the president of Argentina, and he actually did very well. So the theory behind it was it mimicked an open repair by placing an endograft with a seal on the top in the aorta, and then sealed graft in the iliacs, and totally excluding flow in the aneurysm sac. So that's the main principle of it. The first EVAR devices were pretty awful looking. They're very barbaric. Here's kind of what some of them look like. It's amazing that they put these in people. Over time, they've gotten significantly better. Multiple companies are making them with less complications involved. They prevent rupture. They're minimally invasive. Usually we can do them percutaneously with just small sticks into the groin. They have a lower 30-day mortality, lower morbidity, shorter hospital stays, and quicker return to full function. The steps of EVAR are fairly straightforward. You gain access. You can evaluate with IVUS, and you place your main body, shoot your picture, you cannulate your contralateral gate, and then you angioplasty the stent graft. A non-complicated aortic aneurysm can be fixed in about 30 minutes. And then here is just a little cartoon of how it's actually deployed in the body, and that's your contralateral gate. You usually deploy another limb to seal the bottom. Each of these endografts have IFUs that are basically dealing with how much neck, good healthy aorta you need to provide a good seal zone. We use CT to guide that. We also look at not only neck length, we look at the angle of the neck. So here you can see how we calculate infarenal neck angle, and the majority of the devices that we use, the angle needs to be less than 60 degrees. And this is to avoid endoleak. There are 5 different types of endo leak that you can happen. These are complications after the endograft is placed. So the first type would be, and the first type is pretty bad type. It's a leak from the top or the bottom, so not a proper seal in the seal zones. Type 2 is you actually can get back bleeding from lumbar vessels going into the sac and causing enlargement. Type 3, we don't see very often. It's actually a tear in the material or separation at graft components. Type 4 is due to the porosity of the graft. So the old grafts used to sweat blood through them, and then they coagulated. So you could see that complication. Type 5 endoleak is the mysterious one where there's no evidence, but the sac keeps growing. And it's also called endotension. So Aptus endo anchors. Aptus endo anchors are a tool that we can use to prevent a type 1A endoleak, an endoleak from the top. So when we have, you can see they're basically like little screws that go through the graft. And here's an endograft in the wall of the aorta, and you can see it being placed. They secure the endograft to the wall of the aorta. And in so doing, they can do 2 things. One, they make a secure seal zone. They can increase your seal when you have a wide neck or angulated neck. The other thing they do is that you've got to realize that over time, all aneurysms will grow. Even if you repair them with an endograft, they're still going to grow. And so what this does, this prevents the graft from slipping when the aneurysm grows. And the graft and these anchors are holding the aneurysm in and preventing growth, preventing endoleak. The other option we have is fenestrated endografts. When we're dealing with a very difficult neck of the aorta. This is a 63-year-old male with diabetes and hypertension referred to us from podiatry. He was a 2-pack-a-day smoker, had a right-sided carotid bruit, and the workup revealed a 5.5 abdominal aortic aneurysm. But here's his CT scan, and this is the problem. There's really not a great neck below the renal arteries. You see the renal arteries, this is kind of what we call almost a pararenal. It's butted right up. So you can't fix this with a standardized infrarenal endograft. You're not going to seal. You're going to wind up with a type 1A endoleak. And here's the sagittal view. You can see it goes above or at the level of the renal arteries. So you've got to figure out what you can do. You need one of these kinds of rooms to do it. And here we cannulated the superior mesenteric artery. We put a marker stent in the origin of the artery. We also did that for the celiac artery as well. And then we deployed the endograft. You actually deploy the endograft and you cover all those arteries. And then you take a small laser and you laser a hole through each one of these arteries at the previously placed stents. So that you get perfusion back to vital organs and the kidneys. And so here we've gone through the graft, put a hole in it, ballooned it, and we're shooting a picture now in the right renal artery. This is in the left renal artery. Then we add an additional stent, additional covered stent, back into the main body of the endograft, and that is your fenestration. You complete the 2 iliac limbs, and you should get a nice picture that looks like this at the end, where you're excluded and everything is perfusing. And you have excellent seal. Here's a second case. This case we actually did last week. This is a 70-year-old male that was referred to our office because he had a 2-week history of gross hematuria and significant left pelvic pain. He was a 50-plus pack year smoker. On exam, he was very tender in the left lower quadrant. His primary care, because of the hematuria, sent him for a CTA. We saw the CTA. Actually, I saw the patient before looking at the CTA, and I felt his belly, I felt the aneurysm, and I heard about the hematuria, and I said, oh my goodness, he's ruptured into his bladder. But fortunately, he didn't. He had a recurrent adenoma in the bladder, which was bleeding. But if we look at his CT scan here, the iliac aneurysm is very large, it's about 6 centimeters. We normally recommend repair when it's bigger than 3, or 2.5 or 3. He also had about a 4.5 centimeter abdominal aortic component here. So the question about this aneurysm, when you have aneurysm in your landing zone, you've got to pick what is going to be the best landing zone. So if you pick here, where you land your graft, you're going to get a type 1B endoleak. This is a much better landing zone. You can seal there. However, if you don't do anything about that artery, you're going to wind up with another type 1B endoleak, and that's the internal iliac artery. So if you just cover that, it will leak. So what we wound up doing is putting coils in here and doing a coil embolization, covering that, and then extending down and sealing into the external iliac. So here is a picture of the internal iliac on that side. We placed a very nice large coil that sealed it off. We placed our main body, and this is our final picture. If you note, we also put some Aptus endo anchors in there as well, because we had a little bit of what's called a conical neck, a neck that tapers down, looks like a triangle or a cone, and that was to improve our seal. And we had excellent seal, no evidence of endoleak at the end of the procedure. So as you see, endovascular repair has really increased in terms of volume of cases over the years, whereas open AAA has decreased. I'm going to skip some of these. Surveillance is a huge part, post-op surveillance of the endovascular repair is a huge part of especially looking at the sac and making sure that we're getting sac regression or that it's staying the same. We already talked about endoleak treatment. Ruptured abdominal aortic aneurysm, very large problem. Again, we talked about the risks. The 12-month risk of rupture here for our sizes proves that, above 5.5, we probably need to consider fixing. I'm going to skip that. The idea of pre-surgical aortic control has been around for a long time. It's the emergent placement of an occlusion balloon. It's equal to the clamping the aneurysm or clamping the aorta to prevent further bleeding. We now can do it with a Reboa device that actually you can do it in the ER, and ER doctors actually can get trained to do it. And they don't need imaging. You can put it in and occlude the aorta and support somebody until they get to the operating room. Again, this is open repair with a Dacron graft, and there's, like I said, multiple complications that occur. Risk score for mortality for patients that rupture. You can see there's about 4 risk factors that's going to predict mortality. If you have all 4 of those risk factors, you got 100% mortality. So that's how important this is. Again, you need one of these great rooms to do it. Here was a rupture at Park Ridge in 2022. Patient came in. You can see on the left just a huge rupture. It was successfully contained with an endograft very quickly, within 90 minutes, which is the goal. But the patient eventually expired and didn't do very well. So again, rupture of the aneurysm, very high mortality event, and it's the sometimes first and only manifestation of disease. And this is where ultrasound techs can come in and save lives. All right, thank you so much. All right. Our next section, we're going to continue on. Session 4, deep venous disease, and also a live case presentation. Oh, sure. Anyone have any questions? Yes. It's probably, like if you put the patient on heparin, you have to that's one of the steps in the Reboa will be a full heparization. You can do it for a good amount of time, probably 20, 30 minutes. Enough to get the patient to the OR and get ready to fix. Any other questions? Okay, fantastic. Moving on to session 4, deep venous disease, and we'll start with our speaker, Tina Creek. Come on up.